here's my title slide. So I have no disclosures to reveal. So my title, I thought I was very witty when I came up with the title. And then over the weekend, I was looking through my transfusion journals and I saw this title and I felt offended, like I had been scooped. And apparently people in transfusion medicine are really into Shakespeare and Hamlet. So that's where I got my title from. And over the weekend, I saw this. So just letting you know, I came up with it on my own. So I have some objectives for this talk. I want you to be able to identify schistocytes and associate their presence with the pathophysiology of the underlying disease process and their respective laboratory findings. When you see schistocytes, I would like you to be able to formulate an appropriate differential diagnosis for the schistocytosis. And also, as pathologists, I want us to be able to utilize lab and clinical investigation methods to determine what the etiology is and if TPE is appropriate for each respective patient. So I have schistocytes, exclamation point, and I have that because people tend to sort of have a knee-jerk reaction when they hear schistocytes. So I'd like to first tell you, describe what they are a little bit. So they're described as small, irregular, or triangular or crescent-shaped red blood cells with pointed projections. They have lost their shape, so they don't have an area of central pallor like you would see in normal red blood cells. They can be counted with automatic counters, but the gold standard for identifying schistocytes is to actually look at them under the microscope. So I have some examples of schistocytes here. This arrow here is pointing to one that looks sort of like a helmet, and they're referred to as helmet cells. Actually, that one has a little bit of central pallor, and we see some other fragmented cells here. And what you can see is it has very pointed edges. And you see this one here looks very triangular, and these are just red cells that have basically had a bad day and have been damaged in the intravascular compartment. So the first thing is you have to know what a schistocyte is when you're looking at it and looking for it. So it's nice to know what a schistocyte is, but the quantity also matters. So there's a certain threshold where you start to really pay attention to your schistocytes. So more than 2 per high powered field is, I would say that's significant, or if you count and it's more than 1% of your red blood cells. And sorry about that. And the reason I am talking about schistocytes and how people sort of freak out when they hear schistocytes is because the one thing you think about is TTP. Sort of like when a person says, I have chest pain, the first thing you think about is heart attack. You go to the most serious thing first. So what I want to do is just go through some different etiologies, different disease processes that have schistocytes, and have you walk through how we proceed clinically and what follow-up labs we do. And also in TTP, you will not have to hunt for the schistocytes. You won't see one schistocyte on the periphery on one end and then maybe another one. You will not have to look for them. They actually sort of jump out at you. In the first field, you'll be able to see schistocytes. So as I said before, schistocytes are indicative of intravascular hemolysis. Some etiologies are more pressing than others, and that's what we're going to get into towards the second half of this talk. So the process that I'm really talking about today is thrombotic microangiopathy, and it's described. So one component of it is microangiopathic hemolytic anemia. Microangiopathic refers to the processes going on in small vessels, mostly the arterioles and capillaries, and the hemolysis is happening in those areas. So we can have microangiopathic hemolytic anemia and microvascular thrombi and thrombocytopenia. We call this thrombotic microangiopathy. And what happens here is in the small vessels, you get thrombi, and what they do is they occlude the vessel, and so there's no blood flow to the respective organs, and you end up with tissue damage. And the organs that are mostly affected with thrombotic microangiopathy, I would say number one would be the kidneys. Also, I think number two would be the brain in my experience, and also the adrenals and pancreas. And we'll see why this is important in a little bit. So when you suspect that a patient has thrombotic microangiopathy, the first thing you want to do is, well, one, you want to get history, but, look at their labs. And I like to look at their hemolysis labs first. And what I'm expecting to see in thrombotic microangiopathy is anemia, elevated LDH. And the reason you see elevated LDH is because when the red cells lyse, when they hemolyze, they release LDH. But also when you have occlusion in the vasculature, you have ischemia in your organs. And so some of the cells are dying, they're stressed, they're upset, and they release LDH as well. So also as a result of the hemolysis, you get free hemoglobin in circulation. And the body has a very nice method of mopping up the excess hemoglobin with haptoglobin. And so your haptoglobin will bind the hemoglobin and your detectable haptoglobin levels will decrease. However, you need to be careful with haptoglobin because it's a positive acute phase reactant. So in a patient who's under some sort of physiologic stress, their haptoglobin may be falsely elevated. So that's something you always have to keep in mind. As a result of the hemolysis, you'll have unconjugated bilirubin, and so that shows up with an elevated indirect bilirubin. If the patient is available to compensate and respond to the hemolysis, you should see some degree of reticulocytosis. And if there is enough hemoglobin in the circulation, you will actually see hemoglobinuria on urinalysis. So the urine will be red, and you look at it under the microscope and you will not see any red cells. So this is the star of my show here, thrombotic thrombocytopenic purpura, called TTP for short. And there are some points I just want to cover initially about TTP. It's a clinical pathologic diagnosis. So you have to take everything into account. There isn't just one thing that's going to lead you to a diagnosis of TTP. And the point of this talk is to differentiate between TTP and other thrombotic microangiopathies, which sometimes is very difficult because a lot of the laboratory values that you get, a lot of the symptoms will overlap, and it's really hard to tell one from the other. For adult cases of TTP, they're often due to ADAMTS13 autoantibodies or inhibitors. So, as I said before, no single lab value, sign, or symptom is going to initially direct you to TTP. TTP can be present with the normal ADAMTS13 without neutralizing antibodies. It has been reported. So you have to take everything into consideration when you're considering giving this diagnosis to a patient. So TTP is a process that results from a decreased ADAMTS13 level, either from it's not present, it's not being produced, or it's being cleared or neutralized by an antibody or an inhibitor that is stopping it from doing its function. So it can occur at any age, but most of the time you see TTP in adults. You see it in females more than males. Acquired TTP is a little bit more frequent than familial TTP, but it's a very rare disease. But I would not think that with the amount of TTP calls that we get here. It says it's very rare, but I mean, we have multiple TTP patients each week. Now, the really important and scary things about TTP are one is a hematologic emergency, and you have to act quickly on it, because if it's not properly treated or treated quickly enough, it can be fatal. And the patient can go downhill very quickly with TTP. Like from the time they could present and be deceased 2 hours later. So that's why you have to really keep a high index of suspicion and act appropriately when you suspect this. So the pathophysiology of TTP is not an instantaneous process. Sometimes a patient will have these sort of weird, unusual symptoms weeks before they actually present with what you would diagnose as TTP. I read about some children with TTP, and one child, before each episode, she had congenital TTP. She would sleepwalk. She also had an episode where she climbed on top of a bookshelf and laid down and had no idea how she got there. Another case was a little boy with TTP, and he thought his bag of plasma was a lunchbox, and he wanted his nurse to remove it. And, the presentation can be dramatic or really subtle. Some patients come in and they say, I feel fine. They just told me to come here because my platelets were low. Or you could hear of a patient that has presented with severely altered mental status and is unconscious. So when we talk about TTP, there's a classic triad. And I say in most patients with an asterisk there, because you will see some combination of this triad, but you might not see everything. So you would expect to see hemolytic anemia, thrombocytopenia, and some degree of neurologic symptoms. And the neurologic symptoms might not be very apparent. So some patients might have word finding difficulty. They might have a little bit of confusion. One patient that I had was stuttering just a little bit. And I asked his family, does he usually stutter? And they said no, which sort of made me think, yes, this is really TTP. Some people have headaches. So they can be very vague, or they could present, obtunded. So now there's a triad. You're more likely to see the triad, but actually there's a pentad that was developed in the 1960s to sort of clue people in that TTP may be the disease process at work here. So the other two symptoms or signs are fever and renal dysfunction. And to be honest with you, I have never seen a patient with the full pentad. The most I've seen is 4 out of 5 of the classic symptoms, signs and symptoms. And the classic pentad, you only see it in maybe 5% of cases if you're lucky. So you don't need everything to suspect TTP. So what do we do with this information? The reason I'm telling you all of this is the presentation can be very murky. It can be hard to figure out exactly what's going on. What can you do to figure out what's going on with the patient? And luckily, there's a tool for that that's about 25 years old. This is ADAM-TS13 testing, and I'll talk about that in a little bit. So when I say that at first, when you first say it, you're like, Adam who? Adam what? And so I'm going to go through it, and we'll talk about what the acronym stands for. So A, disintegrin and metalloproteinase with a thrombospondin type 1 motif, member 13. So this is the acronym for ADAM-TS13. I put this here to remind me that it's mostly made in the stellate cells of the liver, but it can be made in small amounts from other places. And because I love molecular biology, I just had to put a picture of the molecule in here. So this is your TTP molecule. This is the active site. And what it does here is it cleaves von Willebrand factor. And we will go into the pathophysiology actually right now. So this here is a schematic of von Willebrand factor. And what happens is that when you have endothelial activation, your von Willebrand factor will attach to the P-selectin on the exposed endothelium, and then it will polymerize right here. So this, it will join another sulfur, which is the cysteine, and it will form a disulfide bond here, and it just links on, links on, links on, links on. And so what you get is basically a long multiple of von Willebrand factor. And what that is referred to as ultra large multimers or unusually large multimers. So this is what happens when you have exposed injured endothelium. And what should happen under normal circumstances is your atom TS13 comes and cleaves the ultra-large von Willebrand multimers at this A2 domain. And so it's sort of controlling the process, because when you have von Willebrand factor, waving inside the lumen of the vessel, remember that platelets attach to von Willebrand factor, and this is one of the first steps in hemostasis. So you have your exposed von Willebrand factor, and then the platelets come in and form the platelet plug. And so the thing is, when the von Willebrand factor polymerizes and becomes a multiple, yes, it attracts platelets, which is good for thrombosis. And then when it's in the lumen, the shear stress actually pulls the von Willebrand factor into a more open conformation and exposes this active site for atom TS13. But if atom TS13 is not there, you have von Willebrand factor stretching out into the lumen, catching platelets, and shearing red cells in the process. So this is where you get your microangiopathic hemolytic anemia, and you have your thrombosis. Put those together and you have thrombotic microangiopathic hemolytic anemia. So there are a few things that have come about in the last about 20 years, and this is atom TS13 testing, and there are 3 things that we look for. Generally, when we send out testing for atom TS13, we will want the activity to see how well it's working, and we will say reflex to inhibitor antibody. So if we see that the activity is decreased below a certain level severely, like 10%, then there will be testing to see if there is an inhibitor or an antibody causing the decreased activity. If the activity is in the normal range, let's say it's like 85, you will not test for the inhibitor and antibody. So I mentioned 10%. I didn't just make that up. 10% is sort of the threshold for severe deficiency. With a lot of coagulation and hemostatic processes, you need a certain level, to a critical level of whatever enzyme or factor before you start to really have symptoms. And for atom TS13, that seems to be about 10% where you will see TTP. So if you have a low activity in addition to an inhibitor and or antibody, that is very specific for TTP. The problem is most labs will not have the means to do atom TS13 testing. In most places, it is a send-out lab. And so when you get the patient and you draw the atom TS13, you're going to have to wait at least 1 business day to find out if it's TTP. And that's usually just to get the activity back. The inhibitor and antibody usually take longer. So this testing is not helpful at all in your initial management due to the turnaround time in this potentially emergent scenario. But when the atom TS13 does come back, it will guide your further management of the patient. So with TTP, there are some options to treat it. One thing you can do is replace atom TS13 with plasma. You can interfere with the mechanism of TTP, which is the von Willebrand factor interacting with the platelets to cause thrombosis. And then these multiples in turn cause shearing of the red cells. So you can interfere with the mechanism by using a drug called Kablivi, which we will talk about later. When these patients come in, one of the first things that happens is they basically get hit with steroids. And what we are trying to do is reduce synthesis of the inhibitor. And then, as the patients progress, maybe they're not responding as well. Maybe the clinical team will escalate to rituximab to deplete the inhibitor or antibody to reduce the synthesis. But the thing that's important to us is the depletion of the inhibitor. And this is where TPE comes in. So when you talk about TPE, you have to have rules, guidelines for when to do it. So I'm just going to quickly go through the ASFA guidelines. I apologize if most or all of you know about these, but I just want to cover these quickly. So I call this my Bible of apheresis. When I have a request to do TPE for a certain diagnosis, I look at my guidelines. And the latest issue came out in 2019. They're released every 3 years. So there are 4 categories for treatment of different modalities by apheresis. And apheresis could be plasmapheresis, red cell exchange, leukapheresis, platelet pheresis. And so what it does is it tells you for which disease process, which modality you use, and how likely you should be to use it. And so it gives you category definitions, and they go 1 through 4. So category 1, this is a disorder where apheresis is accepted as a first-line therapy, and you can use it by itself or with something else. So an example of a category 1 indication is TTP. Another one is Guillain-Barré syndrome. Another one is myasthenic crisis. So category 2, these are disorders where the team has already tried something, but apheresis is a second-line therapy, and it can be standalone, but more often than not, it's in combination with another treatment. And an example of a category 2 definition would be maintenance plasma exchange for myasthenia gravis. Category 3, so this one is where it gets a little iffy, and I start to get a little uncomfortable with doing apheresis. And these guidelines are based on research. So for category 3, the role of apheresis, how effective it may be, has not been established. Maybe because it hasn't been researched and there's not evidence against it, or there's conflicting evidence against it, for and against it. So you can do apheresis if a patient has a category 3 indication, but you just have to take each case into consideration and decide and weigh your risks versus benefits and decide whether or not to proceed. Category 4, this is my favorite category, and I will tell you why in just a minute. So these are disorders in which evidence demonstrates or suggests that apheresis has no effect whatsoever, or is actually harmful. Because to do apheresis is actually an invasive process. You're most likely placing a central line, exposing a patient to citrate, and you're taking some of their blood out of their circulation and sort of making them anemic. So if you try to do apheresis for a category 4 indication, you should get IRB approval. And so category 4 to me is a no-go zone. And there are actually some category 4 indications that are no longer in the guidelines that were in the guidelines when I first started. And schizophrenia used to be a category 4 indication for apheresis. And I know you're thinking, what is going on here? And it just should not be done. And so it was so absurd that it's not even in the guidelines anymore. So with the ASFA guidelines, they're useful to decide what you should do initially for a patient with some sort of disease process, or longer term therapy if you know the established diagnosis. With category 4, I just think they're sort of entertaining. The indications, I would say, are frowned upon in clinical medicine. If it's not in the guidelines, do not initiate TPE, because with Category 4 guidelines, you need IRB approval. If you do TPE or any other apheresis procedure for something not in the guidelines, you're really opening yourself up for a world of trouble. So let's say you have a patient and they come in with a picture that looks like thrombotic microangiopathy, might be TTP. And so it's on a differential. Actually, I would prefer it be on your differential than not, because you need to have an appropriately wide differential to make sure you don't miss TTP. And so you're suspecting TTP and you want to know what to do next. What's your next step? And there's a tool. Oh, I have a question here. So what do you do with the information you have? I almost sort of gave it away. Immediately start TPE. Immediately give a hemostatic dose of plasma. Or C, immediately assess how likely TTP is the diagnosis. And I know I can't interact with you, so I'm just going to go to the next slide. The answer is C. The first thing you need to do is use a certain tool that I will speak about in just one slide to see if TTP is the likely diagnosis. When I started back in my day, you just had to go off of sort of, some lab values and, your gut feeling about what this could be. But there is something that was developed just a few years ago that will help us with that. And the goal of this is to not miss treating TTP. And so if you start TTP, what you want to do is stabilize the patient until you can confirm TTP or rule it out. And then once you confirm or rule TTP out, you can determine if you need to do further TPEs. So the tool that I was referring to is the PLASMIC score. And it was developed in 2017 by scientists and physicians at Harvard. And it's the Harvard Thrombotic Microangiopathy Research Collaborative. And what it does is it predicts the chances of a patient having an ADAM-TS13 activity of less than 10%. And it tends to be very sensitive, and specificity can range between 46 and 92%. And I think the reason for that is some parameters are weighted more than others when you look for specificity. So let's look at the PLASMIC score. There are some things you need to take into consideration when using the PLASMIC score. It should only be used with patients with a platelet count of less than 150 and with sufficient schistocytes on the peripheral smear. If they have a count less than 150 and no schistocytes, I really would not expect it to be a TMA. It should be used in only hospitalized patients who have not started plasma exchange. And it should not be relied upon solely to determine whether or not this patient may or may not have TTP. You still have to take everything into consideration. And as with any criteria or laboratory test, it needs to be used judiciously, because if you get a value that indicates disease, you're obligated to evaluate and treat that issue. So be careful with the patients that you use this on, because, and you need to use it correctly, because if you get a score that's high, you need to start TPE. So the parameters, and the PLASMIC score is an acronym. P is for platelet count. So what the scientists found is that platelet counts under 30 are more likely to be TTP. For each of these parameters, the patient gets 1 point. So is there L is looking for signs of hemolysis. So is their indirect bilirubin elevated? Do they have an increased reticulocyte count, or is their haptoglobin undetectable? Again, 1 point. If the patient has active cancer, and this is described as cancer, and they're getting treated for anything other than a basal cell carcinoma. So if the patient doesn't have active cancer, the chances are that their presentation is, obviously not due to that and could possibly be TTP. Does the patient have a history of solid organ or stem cell transplant? this is in here because TTP has been reported, or TTP-like syndrome has been reported with transplant patients. So if you see that in the history, more likely there's something else going on than this disease process. It's more likely a mimic. The MCV should be less than 90. INR less than 1.5. Generally, these patients are not coagulopathic. So the INR should be, fairly normal. And the creatinine can be elevated, but it's usually not very elevated in TTP. So you get 1 point if the creatinine is less than 2. And I'll show you some instances when the creatinine is higher than that. So I made this table, and it's just telling you what will happen when you do the calculation for the PLASMIC score. And there's a calculator on the website MDCalc, and you type in everything and it gives you the score. So if the score is 0 to 4, there is a low risk of this patient have a severe deficiency in atom TS13. Score is 5, they have an intermediate risk. If the score is 6 or 7, they have a high risk of having a severe deficiency in atom TS13 and very likely TTP. So what I'm going to do now is I'm going to go to some cases. I know you can't interact with me, but I'm just going to go through them and sort of walk you through the process that I go through when I'm presented with a certain type of patient. So case 1, this is actually a real case. There's a 83-year-old female, past medical history significant only for hypertension, hypothyroidism, things that are very easily controlled with medication. And she presented unresponsive. When her CBC was drawn, she had a platelet count of 19,000. She's afebrile, she's not tachycardic, her respirations are fine. Her systolic pressure is a little elevated, and diastolic is a tad bit low, but nothing that I would really be very concerned about right here with the vitals. But what bothers me is the altered mental status and the platelet count of 19,000. So let's look at her labs. Her creatinine's 1.5. That is elevated, should be at the most 1.1. She's actually not anemic and does not have schistocytes. However, her reticulocyte count is up a little bit. It's just 2.3%, but this is still below 2.5 as indicated by the PLASMIC score. Her MCV is 96. We already talked about her platelets. Her hemoglobin, her haptoglobin is low, and this can happen. You don't need a lot of free hemoglobin to decrease your haptoglobin. Her LDH is 534. Her troponin is borderline, so that makes me think maybe some ischemia here. And her INR is, okay. I'm not, really scared for her bleeding from a deficiency in clotting factors. What I'm really worried about is the platelet count. So, in the meantime, you think this could be TTP. The patient's very sick. What recommendations do you make? So 1, if there's going to be a delay in starting plasma exchange, let's say the patient has to be transferred from an outside hospital, I would ask the team at the transferring hospital to transfuse plasma before they send the patient. If that is not possible, I would have the patient transfuse once they arrive. Do not transfuse platelets unless there is significant bleeding, because when you're adding more platelets, what's going to happen is they're just going to get caught up in the microvasculature, and you're going to exacerbate your problem of tissue ischemia. You do need to let the team know that vascular access is required. And generally, a central venous catheter is placed because it's quick and it gives you great access, and you can run your procedure at a high flow rate. You should order or have the team order a pre-transfusion, pre-plasma exchange specimen for atom TS13 testing. So I know this is sort of hard to see, but for this patient, I put in her parameters to get her plasma score. And she came up with a plasma score of 6, which is high risk. And this correlates to a 72% chance of having a severe ADAMTS13 deficiency. So I think, this is very likely TTP. So I would start TPE as soon as possible. So this patient, we think she has acquired TTP. She's an adult. We start TPE, and her platelets start to go up, and her hemolysis labs start to normalize, and her creatinine starts to go down. So let's look at her ADAMTS13 results. She had 0% activity. But remember, just a few slides ago, her hemoglobin was not bad. I think it was in the 11s or 12s. However, she had an inhibitor, and she also had an antibody. And what happens is, you're going along and you're thinking, okay, we're curing her. Her labs are normalizing. What could go wrong at this point? And never to ask that question. So we have a little bump in the road. Her platelet count stalls, stops increasing, and starts to go down. And her hemolysis labs tend to derange a little bit more. Her hemoglobin goes down. Her haptoglobin will go back down. Her LDH will increase, and creatinine starts to tick back up. So you're thinking, okay, she has TTP. We're treating her with the first-line therapy. She's also getting steroids. What's going wrong here? Like, what are we doing wrong? And the answer is nothing. Often with patients, if they initially respond to therapy and then they start to stall out, what I've seen in my, 5 years of experience doing this is the patients often have an occult infection. So you continue TPE. What you need to do is investigate for a source of infection. And a lot of times it will be a urinary tract infection. I've seen it where a patient had abdominal surgery and his intestine was nicked. And so he had an infection in his peritoneal cavity. And so you want to check, if they had surgery, see if there's possibly any infection there. So for this patient, she actually did have a UTI. And some of you may remember from medical school that a lot of patients that are older will tend to have UTIs that are not really symptomatic. So what you do is, the team will treat the infection and their labs tend to improve. Okay, second case, similar, but a little different. We have a 9-year-old female. She presents to the ED with petechial hemorrhages, diffuse petechial hemorrhages, epistaxis. She had a history of recent mycoplasma pneumonia infection. So she's anemic. She has schistocytes, and her platelet count is 8,000. Her MCV is 85, about normal. Haptoglobin's undetectable, less than 8. Her INR is fine. Her creatinine is increased, but, not horribly increased. So I know you can't see this well, but just trust me. I calculated her plasmic score, and it's 6, which gives, again, a 72% chance of her having a severe ADAMTS13 deficiency. So what I suspect is going on here is congenital TTP. The other name for it is Upshaw-Schulman syndrome. The interesting thing is it can present in childhood or adulthood. And it's due to no inhibitor. You just have severely decreased ADAMTS or absent ADAMTS13. And what happens is you would think if they don't have ADAMTS13, then they would thrombose, immediately. But there needs to be something else in addition to absence of ADAMTS13 to trigger this. which is similar with acquired TTP. So a lot of times it's something like post-infectious where they would develop this. And the thought is that there may be some sort of mimicry, molecular mimicry behind this, and the body sort of overreacts. And then it tips them over and they start to have symptoms. So the treatment for this, once the diagnosis is established, is to treat with regular plasma transfusions. So I have a question for you. So let's say this patient presents with these symptoms. It seems like TTP, and it could be congenital, maybe not. So what should we do? Question A, no, this is obviously congenital TTP and can be treated with plasma transfusion only. 2, this may be congenital TTP, but there is no way to know at this time. Answer C, yes, this is acquired TTP. This is just a small adult that needs TPE. Answer is B, it may be congenital TTP, but you don't have your ADAMTS13 activity back, you have your inhibitor, and you don't have your antibody. So to be safe, you need to proceed with TPE. Case 3, this was a case that I had the very last week of my fellowship as I was trying to move out of my apartment. I got a call about a woman who was 22 years old, 16 weeks gestation, and she was at one of our sister hospitals. And she had a platelet count of 15,000. Her hemoglobin was bottoming out. She was at 5.3 grams per deciliter, lots of schistocytes, and she had a headache of 1 week duration. Also notable, her blood pressure was 232 over 131. I actually did not have to look back for this BP. It is burned into my memory. Creatinine is elevated. MCV is 85. LDH is increased, and her haptoglobin is undetectable, less than 8. She has marked reticulocytosis, so she's responding to the anemia. And the team requires urgent TPE. So I calculated her plasma score again. She got a score of 6, 72% chance of this being severe deficiency of ADAMTS13. So we, get everything started for TPE. So when I placed the orders, I put thrombotic microangiopathy as the diagnosis because her blood pressure was so high. And sometimes you will see that can cause a picture that looks like thrombotic microangiopathy that could look like TTP. So I asked the clinical team to control her hypertension. And it seemed like she was stuck in the ED. There were no patient beds available. And so I ordered a hemostatic dose of plasma due to the delay in placing the line, just to tide her over until we could get the procedure started. In addition, she received 2 units of RBCs because she's very anemic, but she's also 16 weeks pregnant and there needs to be adequate oxygen delivered to the fetus. So nothing happened overnight. Actually, I take that back. The line was placed and no one called me overnight. So at 6 a.m., I get a call that the line's been in for 5 hours. So I make my way to the hospital. And her systolic blood pressure is still in the 180s. And so I called the maternal fetal medicine team and I said, would you please lower her blood pressure? And one thing I noticed, I looked at her value. So of course she had been transfused, but she did have a lot fewer schistocytes. And, the ADAMTS13 was not back yet. So we started TPE. And what I was expecting was the ADAMTS13 to not be significantly decreased. I was pretty sure that this was due to malignant hypertension. So we got her test results back and her activity ended up being 66%. So there was no need to reflex to inhibitor or antibody studies. So this is a case of malignant hypertension. This patient actually had a history of preeclampsia in a previous pregnancy. So what happens is the blood is under so much pressure that it actually is sort of fire hosing the endothelial wall, and you get endothelial injury. And then when that happens, as I said before, you get ultra-large von Willebrand factor multimers, and you have this exposed von Willebrand factor, which will then aggregate platelets. And then when the red cells come through, they will shear. So you have a thrombotic microangiopathy. There is one caveat though. In these patients, you can see a decreased ADAM-TS13. It's usually not less than 10% though, because what happens is, because there's so much shear stress in the vessel, the von Willebrand factor is sort of being like held open by the pressure. And this makes its cleavage site very available to ADAM-TS13. And so what ADAM-TS13 will do will come in there and try to, cut up your von Willebrand factor. And what this ends up doing is actually decreasing your level of available ADAM-TS13 in the serum. So this is why sometimes you can have a decreased ADAM-TS13 activity with malignant hypertension. Let's skip this one. So what I always do is I go to the ASFA guidelines. Malignant hypertension is not listed. TPE is not indicated. And my example was, it's so absurd to do TPE for this. It's not even in the guidelines. And my example, once again, was schizophrenia, which apparently must have been done at some time for, TPE must have been done at some time for the treatment of schizophrenia. Case 4. We have a 5-year-old that comes in, they're very lethargic and pale. The parents report that he's been unwell for a week. He initially, when this all started, he had abdominal pain, nausea, and watery diarrhea. So pertinent labs, he's anemic. His MCV is 91. He does have marked schistocytosis. DAT is negative, so it's not some autoimmune hemolytic anemia. His platelet count is 38,000. INR's not too bad, it's 1.3, but his creatinine is really elevated. So the additional info is, in the course of this, the parents tell you that the child often drank apple juice. And so they were asked what kind, and they said Odwalla. Some of you who have been in this area for a while, quite a while, I would say the last 24, 25 years, will probably remember this case. I'll show you what it was. So this is the Odwalla juice. And what happened was Odwalla would not pasteurize their juice because they felt that it interfered with the true flavor of their juice products. So I calculated this child's plasmic score, and it was 3. And so he has a low risk of having a severe ADAM-TS13 deficiency. Actually, 0%. So this is pretty obvious. This is a case of hemolytic uremic syndrome. It usually occurs in children. It can happen in adults, but generally, it follows a diarrheal illness due to the sugar toxin producing E. coli. The poster child for this disease is E. coli 0157H7. For those of you who are residents, I would really remember that because that will show up on boards. So I got this story actually from an episode of Forensic Files, and it was featured there because there was this outbreak in 4 states, and 28 children were sick, and 1 2-year-old in Colorado actually died from this. And what investigators did was they used DNA fingerprinting to link these different samples of E. coli, and they found that they were the same and that they came from the Odwalla processing plant. And so the reason I really like this case is because it shows the different things that pathology can do to get to the bottom of a diagnosis. And DNA fingerprinting, it's the same thing that's used for paternity results, to identify missing persons who may have been found. So what happens here is the bacteria produces a toxin, and it goes, and what it does is basically attacks the vascular endothelium directly. But also when it does this, any tissue that gets attacked that is injured is going to release inflammatory chemicals, cytokines. And also when the endothelium is damaged, you get your von Willebrand factor multiples. And then also there is some degree of activation of the alternative complement pathway. And so you get a lot of inflammation, you get microangiopathic hemolytic anemia with thrombosis. So you have a TMA picture, and the patients end up with organ damage. In HUS, the main one is the kidney, and it can look pretty scary. They tend to have high creatinines. But what you do for these patients, first, you do a stool culture. That will take some days to come back. You can do a stool PCR immediately for sugar toxin. And so you think is, HUS, and so, but you're not sure, so you start TPE. You may not though. It's a category 3 indication if it's due to sugar toxin producing E. coli. If HUS is due to strep pneumo, it's also a category 3 indication. So you can do TPE for HUS. I wouldn't recommend it because generally supportive therapy is what's used for these patients. Okay, case 5. We have a 53-year-old woman who presents with anemia, thrombocytopenia, lethargy, and renal failure. And I'm going to go through this one a little bit quicker. So pertinent labs, her hemoglobin's low, she has schistocytes, her NCV is normal, platelet count is low, but not so low that it frightens me. INR is 1.4, creatinine significantly increased as she has proteinuria. So I calculate her PLASMIC score, and it's 5. So she's at intermediate risk of having deficiency of ADAMTS13 with a 6% chance. So with this being known, I would rather err on the side of caution. And so I would start TPE for this patient. However, her presentation isn't textbook. Her platelets are not as low as what I usually see with TTP, and her creatinine is a lot higher. So with this patient, I would suspect a particular entity, and I'm not going to tell you what it is just yet. So I would strongly suggest ordering complement labs. And would this help me right now? No, it won't. There's going to be a delay in the turnaround time because a lot of times these are also send out tests, and this could be TTP, an emergency, so you would need to get started on plasma exchange immediately. So you have to treat the patient until you have an idea whether or not this is TTP. So you're doing TPE and the patient is not really responding. Her platelet count is going lower, and then you get her ADAMTS activity back and it's 45%. It's not decreased. So I'm pretty sure that this is not TTP. She had intermediate risk. Her creatinine was above 2. Her platelets were not absolutely horrible. So not TTP. But you suspect atypical hemolytic uremic syndrome. So this process is due basically to a complement system run amok. A lot of times it's due to mutations in proteins that actually sort of tamp down the complement cascade. Most of the time it's factor H and factor I mutations, but you can also have mutations in factor B or C3, which actually leads to C3 having a longer half-life. So either your complement is not being suppressed, or you're having complement that's active for longer than it should be. And so, as we know, complement actually it literally attacks tissues, and it injures endothelial cells, especially in the kidney. It loves the kidney. So you go to the ASFA guidelines, and if you look for atypical HUS, it is not listed. So I would recommend stopping TPE. It is not is shown not to be helping this patient. But there's, all is not lost. So for atypical HUS, I would suggest adding Soliris, eculizumab to the treatment regimen. What it is an antibody against C5, the last step before the membrane attack complex forms. And so what you're doing is blocking that and blocking the membrane attack complex, which is what actually, literally attacks to tissues. The thing about eculizumab is clinicians will often balk at using it because it's very expensive. However, if a patient has a typical HUS, they have a very poor prognosis without treatment. And so, eculizumab at one time was the most expensive drug in the world. So this is my joke here. When I thought of eculizumab, it costs $500,000 for a year of therapy. It's no longer the most expensive drug in the world. So if you were into TV, maybe 15 to 5 years ago, you may recognize this man from a beverage commercial, and he is the most interesting man in the world. And I have a little bit of product placement here for Soliris, and I actually came up with this quote at 1:15 this morning as I was trying to go to sleep. And he would say in this case, I don't always use biologics, but when I do, I choose Soliris. Stay microangiopathic, my friends. Okay, I have a bonus case. I'm going to go through it sort of quickly though. So a patient presents with signs and symptoms of thrombotic microangiopathy with renal dysfunction. So you do your PLASMIC score and everything, you start TPE. You later discover that the patient has recently started taking ciclopine 2 weeks ago. And so this is something I just wanted to make you aware of. Just like there's, drug-induced thrombocytopenia, drug-induced hemolysis, there could be drug-induced almost anything. There is drug-induced thrombotic microangiopathy. And we have quinine, some antiplatelet drugs, ciclopine, clopidogrel, cyclosporin, and tacrolimus. Gemcitabine, I have quinine on here twice. Also, some illicit substances have been known to cause TMAs. So IV oxymorphone, MDMA, which is known as ecstasy, and cocaine. So I just want to make you aware that this could be the cause behind this patient's condition. And what you do for this is you stop the offending drug. And so this is actually indicated in the ASFA guidelines. If the patient is taking ciclopine, it seems to be more of an immune response mediated process. It's a category 1 indication for doing TPE. If it's clopidogrel, they think it may be due more to toxicity. It's category 3. For gemcitabine and quinine, it's a category 4. So do not perform TPE, just stop the offending drugs and do supportive therapy. So I deleted one case to make room for this. This is something that actually happened as I walked in the office at 8 o'clock this morning. I found out about this. There was a 47-year-old female who presented with altered mental status. She has a platelet count of 5,000, blurry vision. So the team naturally suggested TPE. Oh yes, marked schistocytes. Her LDH is over 3,000. Her hemoglobin is not bad though. And so we decide, we're thinking this could be TTP, and her ADAMTS 13 was drawn and set off. So my office mate arranged for TPE to start today. but she found out additional information this morning. The patient had a systolic blood pressure of over 200 millimeters of mercury. Her toxicology screen is positive for cocaine and opiates. So recommend controlling, what I would do is recommend controlling the BP and monitor for improvement in lab values. So this patient is a little bit of everything. So she has malignant hypertension, and she also has cocaine and opiates in her system, which, as you saw in the previous case, can cause thrombotic microangiopathy. So the thing is, you don't know for sure. So you have to perform TPE at least until your atom TS13 comes back. So what I would expect, because of the malignant hypertension, her atom TS13 may be decreased, but most likely would not be severe. And so they will not reflect to your inhibitor or antibody. So at 2:51 p.m. this afternoon, 9 minutes before I logged on to this, her result came back and it was 79%. So we successfully avoided doing an unnecessary procedure on the patient. So those were my cases. And the point that I wanted to get across is sometimes trying to figure out which TMA you have is difficult. It's not always clear cut. Generally, there's not a slam dunk sign or symptom that's going to say, this is absolutely TTP. So when you cannot rule out TTP, you should start plasmid change. And you wait for your atom TS results to come back to guide further management. In my opinion, it's safer to stop TPE on a patient who does not have TTP rather than to not start it on a patient who you find out later does have TTP. No one wants to be that person that didn't treat a patient with TTP and the patient didn't do well. So my take-home message is schistocytes do not equal TTP. Just like a positive DAT does not equal hemolysis. It's something you need to investigate, but it's not an absolute. So you can calm down a little bit when you hear someone, calling you saying we need urgent TPE. Schistocytes does not always mean TTP. If you know nothing else, that's what I want you to take home today. So these are my references. I have quite a few. And at this point, I would like to open it up for questions. Also, thank you all for being here with me today and listening to my presentation. I really appreciate your time.
Thank you. I think we have just time for one or two questions.
Dr. Lieberman is asking, how reluctant are treating teams when you propose waiting on plasma exchange or suggest that it isn't indicated?
How reluctant, like how much pushback if I say that I don't think this is indicated?
Correct.
It depends. A lot of times it directly correlates to the patient's clinical condition, how much pushback we get. But if you decide to not do TPE, you need to be really sure, like very certain that this is not TTP, and you explain your reasoning to the team. And maybe, you can compromise if they are like saying, yes, you're going to kill my patient. Well, then I'm like, okay, I would, we can start TPE and wait for the atom TS13 to get back. And a lot of scenarios, it comes here and it can be back in a day. So at the most, you may be out of 1 or 2 TPE procedures, and it still is better to start treatment and stop it later than to miss a potential case.
Next question is, do you have a preference for giving just plasma or a combination of albumin and plasma? So I think Dr. Sang means for replacement fluid.
Okay.
Do we do half and half, or do we do all plasma?
So at Bloodworks, we do half and half, which has worked out fine. So the first half, you will start out with albumin and you just top them off with plasma at the end. Everywhere that I've been, I know all of 2 places before I came here, we were replaced with 100% FFP. But if you can get results with only doing half and half, it's less expensive. You're exposing the patient to less antigens from the potential donors. You're decreasing the chances that they could have some sort of transfusion reaction, like, allergic or trolley, taco, or something like transfusion transmitted infection. So I think it's a great idea to do half and half.
And Bloodworks has been performing with half and half for over 20 years, and we get good results with that.
Yeah. When I first came here, I'm like, what? And then I thought about it, and I was like, that really makes a lot of sense.
All right. I think we're probably over time.
Thank you so much.
Thank you, Ashley.
Everyone is applauding silently from home. So
thank you all. Thank you for being here and applauding. And I hope you laughed at my joke. I worked very hard on that.